One of the things we wanted to talk about, we've heard a lot, a big theme throughout the day has been transparency and owning your data. And one of the topics we wanted to cover is how employers are using their data to make decisions, but also not only to make decisions, but what are some of the barriers, what are some of the concerns? And so I want to thank my panelists. We'll do introductions here in a second because they all bring a different perspective to this topic. And I know as I work with some of them, talk with all of them, I learn so much, again, because it's just a very different perspective. We do actually have a couple of slides. If someone can, there we go. Perfect. Thank you. So, you know, you're seeing a lot of different things in the media today, a lot of different headlines. And one of the consistent themes is the cost of healthcare for families, for workers, the exorbitant hospital bills that individuals are paying. I think of the MRI example that Cynthia mentioned this morning. These are things that are not uncommon. They're like multiple times a day type of experiences. And I know in my role, I get calls from employees all the time. And one of the things I have to say is that I'm here to help you navigate, really, the healthcare system because the patients get caught in the middle. And we know we've heard it earlier, and we heard from Senator Braun about trying to keep the cost of family coverage low in his organization. But here across the country, you can see over the last period of time, many years, that it continues to increase. It's not decreasing. And this is something, I grabbed this graph from the Kaiser Family Foundation. They do a survey every year, and these numbers continue to grow. And this slide, I think, mimics what Chris Whaley had up earlier this morning, where we see the out-of-pocket costs for employers growing more than their wages are. So that continues to become a concern for employers. So how do we manage that? And one of the things we keep hearing is healthcare expenditures are a large portion of employer budgets. The per employee costs continue to grow far above the cost of living. Employers have a fiduciary responsibility. And now we have the Consolidated Appropriations Act, which has created this enhanced awareness, visibility, if you will, of the costs. And access to that data is really key. However, accessing data continues to be a challenge. And the data for employers can be overwhelming. I think we heard also earlier from our speakers that, you know, the transparency and coverage data that's coming in is messy and it's large and you need massive databases. So how is an employer supposed to navigate all of those things? So those are some of the items that we want to address in our panel discussion today. And with that, I'm going to maybe pass it down to the panel and let each of you, maybe if I call off your name, kind of introduce yourself, your organization, and for our audience, highlight if you're an employer, maybe what's the size of your population, your geographic location, and then just for everyone, highlight why you think this conversation is so important, and maybe what you're doing in this space, and just, again, a few minutes so that we can get to some questions and some questions from the audience as well. Candace, we'll start with you from Purdue University.
Afternoon, everybody. I'm Candace Shaffer. I am the Associate Vice President for Benefits and Payroll at Purdue University. And everyone knows Purdue, right? We were in the championship game. That's right.
What sport was that?
Oh yeah, right. Which sport was that? Yeah. So size-wise, we have about 25,000 members on our main plan. We do a couple other plans, but talking about the big one. And we're land grant, R1 Research Institute, but we're in 92 counties within Indiana. But we also, since the pandemic, have grown outside of the border of Indiana, and we are now in almost 44 states, I believe, which adds to all the things, as many of you who are employers would know. So why do I think this is important? I mean, I'm a data nerd, self-professed. I love data, and everything that we do at Purdue is driven around data. It tells us the good things, the bad things, and the neutral things. And I think the main thing that we've done with data, I was charged back in 2017 to save $20 to $25 million off of our plan. And in 5 years, we were able to successfully do that. We've actually cost avoided about 4 times that from our plan. And all of it is due to data and telling us what to do and driving us further. And now where we're at now is what else will the data tell us now that we have surpassed that goal and need to continue to maintain that. We've been able to keep our trend at 1.5% since 2016. 5 years in a row, we have no premium increases. We have done other things with the plan to shift that cost share, but they have not been extreme at all. But like many of you, we're battling now forces that are way beyond us. And how do we combat that?
Yeah, thanks, Candace. Next, we have Chris Deacon from VerSan's Consulting.
Hi. Yes, I'm currently with VerSan Consulting, so I'm an employer of one, and that would be myself. But I was the former director of the state and school employee health benefits program for the state of New Jersey, where we had over 820,000 public sector lives in the state of New Jersey and across the country in all 50 states and several territories with over $7 billion in annual spend. I was there for several years before, and we also did some really innovative things, a lot of payment integrity work, things that weren't necessarily member facing because we have 35 public sector unions. So I know what it's like to wrangle and herd cats. 35 public sector unions to work with. So we did a lot of work on the back end on how to spend our money more prudently and procure more prudently. For example, in 20 months alone, just on payment integrity on inpatient facility, we saved $120 million in 20 months on 4 medical concepts alone. Being big is great because you have a lot of negotiation power. Being big is really hard because when you make really smart decisions, people lose revenue. That $120 million might have been savings to the state taxpayers, but it was revenue to the hospitals that our members accessed. I am definitely sort of a product or a result of having to follow my moral compass and being the product of, seeing what is the sausage making really behind legislation and policy and politics and healthcare and how powerful that can be. And I am here to tell you that it's powerful. And even when you think you are doing the right thing for your state and your taxpayers, oftentimes that comes at a cost and a price of political donations and political power and influence with the hospitals and the carriers. So for the last 2.5, 3 years, I've been taking my voice on the road and really focusing on educating employers in the C-suite on what it means to be a fiduciary, talking about some of the litigation, recent lawsuits. And just a quick Indiana aside, if any of you follow me on LinkedIn, you may have saw that I wrote a letter to Peyton Manning a couple months ago because he has a hospital named after him in Indiana, the Children's Hospital, Ascension. And I thought he should know some of the dirty deeds that Ascension does and some of their revenue cycle management practices, not expecting to get a response or, perhaps for him even to see it. But I was lucky enough to be at the airport in Green Bay, Wisconsin last week. But who should be behind me but Peyton Manning? And I had two choices. I could be the crazy lady that wanted a selfie, or I could be the crazy lady that approached Peyton Manning and told him all about Ascension Hospital and why he should really look more into the organizations that he allows his name to be associated with. I chose the latter, so I'm that crazy lady. With that, I'll turn it over.
Right. I know. We need the rest of the story. I don't know if we have time, but maybe at the end.
I come from Wisconsin, so we're all crazy up there, so no worries.
So next we have Melina Kambitsi from the Alliance. So why don't you give us a little brief intro about your organization?
Yes, of course. Good afternoon, everybody. Gloria, thank you for having us, being here with old friends like Marilyn and Cora. So Melina Kambitsi, I'm the Senior Vice President of Strategic Marketing and Business Development for the Alliance. The Alliance is a coalition of employers. Sean's predecessor, Mike Tomczak, has called us for many years the original alliance, so not to be confused with the National Alliance, but one of these 40 coalitions that Sean is helping us manage, right? We serve in the Midwest, but primarily Wisconsin, as well as Illinois and Iowa, but mostly Wisconsin. Like EFI, Gloria's in this incredible organization, we are the voice of self-funded employers that want to control their cost of healthcare. We are different than other coalitions in that we direct contract with employers. So what we sell essentially is a network of 39,000 providers across Wisconsin, as I said, Illinois, Northern Illinois, and Iowa. And we serve approximately 450 employers. The number is always moving because it is increasing. We've almost doubled the amount of very engaged employers that are part of this coalition in the past 5-6 years. And I didn't raise my hand when Chris said, "Hey, how many of you do you think that it's very difficult to engage employers?" I was going like this because it has taken us, I've been with the organization for 7 years, and it's taken us that long to engage employers. Our employers are engaged, and like Sean said, they are actually smaller in size. So approximately 450 employers, 120,000 lives, belly buttons, to use an insurance phrase, right? So our median size is about 300 to 500. Close to 300. So they're smaller, but they're super engaged. You asked us various sizes, right? So ranging from about 25 employees, 50 lives, all the way to employers that have 20,000 lives. So very, very small and very large, ergo kind of that median of 300. And also from a range of industries. So I wanted to say so many things while the previous panel was presenting, because Sean is again very, very correct. The most engaged employers, public entities, so schools, school districts, municipalities. We have Taft-Hartley accounts, employers that are very engaged. Also manufacturing, and manufacturing understands the concept of lean production. So they are at the core of innovation. So about 30% of our employers are in manufacturing and 27% in school districts, public accounts, municipalities, et cetera. Data, I think we're going to talk more about that, right? But data is at the core of everything that we do. And the way that we've engaged employers is through providing them their data. We have customizable reports. Each employer gets a custom report using their specific data. So I'm not doing a very good job explaining the Alliance because contracts over 34 years, we're also a repricer. So the providers send us the claims. So we also have all of the claims in our system. We reprice the claims, we send them to the TPAs for final adjudication. That gives us an incredible amount of data that Cynthia talked before about gag clauses. In 34 years of contracting, we've never had gag clauses in our contracts. And that is what makes us very, very unique, as well as our contracts are a percentage of Medicare. So we start with Medicare. That's kind of our methodology. We use CMS methodology. And so I'm not going to make the claim that they're a cost plus, but because, some percentages of Medicare are high. There are multiples of Medicare, but that's how we contract. So that's what makes us unique. I guess we'll talk more in a second.
Yeah,
yes.
No. Next is Cora Opsahl from the 32BJ Health Fund, which if you've been here throughout the day, I think Cora's gotten a few shout outs, at least a couple of times. And if you don't know a lot about her organization, it is really cool. So I'm excited for you to kind of do a brief intro, and then we can talk a little bit more about it as well.
Great. Thank you so much for having me. So as Christan said, my name is Cora Opsahl. I am the director of the 32BJ Health Fund. We are a Taft-Hartley benefit fund, which means that we provide benefits to the 32BJ SEIU union and their members and their families. We cover about 215,000 lives up and down the eastern seaboard, but primarily focused in the New York, New Jersey area. But we've got lives in Boston and in Philly and Pittsburgh. And we're a multi-employer plan. What that means is that the contributions to the plan come from over 5,000 employers. The other things to understand is that we have no premium sharing. So it's 100% paid coverage by the employers. We have no in-network deductible, and we have low copays. And we really have a principle of if the member does the right things, they can access free or close to free health care. Which means it's the responsibility of us as the health fund to really, I look at it 3 ways. We have 3 goals. One is to keep our trend at 50% of the national average, because the only way to continue to offer really, affordable benefits is to have an affordable plan. 2, we keep the member at the center of everything we do. And part of the reason we do that is because we wouldn't have jobs if we didn't have our members. And 3, it is the responsibility of the health fund to solve the affordability crisis, but not on the backs of our members. And this is really important because, I think that, the folks in this room, we are committed to finding affordable solutions for employees and for members. And the problem is it's not just raising the deductible or raising the premiums. And for us, because the 32BJ SEIU union, premium sharing is a strike issue for them. And so as the health fund, it's our responsibility to ensure that that is never, hopefully not a part of the conversation. And we look at this in a couple of ways. And one of the things is fundamentally is data. And why do we talk about data, but why is this important? But I want to actually address something that was said earlier on the last panel, which is, why is this important? It's important because employers have to come together to speak out. We cannot do this alone. And the reason we have panels like this and the panel before and Gloria and her amazing conference is because we have employers who are sitting in this room who are coming together to speak out. Because we can't be in positions like I was where I had the president of the carrier call me up and say, as they were negotiating a very large contract in New York, and say, I understand they're too expensive for you, but when I get a phone call from a very, very large investment bank, what am I supposed to do? And the reality is, the way that would not be a conversation, because employers like us, there's not that many folks like us who are calling up and saying, we can't be okay with this. And we have to kind of, really start to have those real honest conversations of how do employers continue to stand up on this stage, stand together to do the things that we're doing. And it's why it's a credit to Gloria and the Employer Forum of Indiana for doing just that. And I just wanted to echo that is that right now there are more employers doing nothing or being quiet than doing something. But I'm really grateful to be here and be able to share the some things that we are doing.
Thank you. And last but definitely not least, Chad Phillips from right here in Indiana, Bartholomew Consolidated School District.
Thank you. Good afternoon. I apologize because I'm probably going to have to leave the panel before it's over. My name is Chad Phillips. I am the CFO and Assistant Superintendent at Bartholomew Consolidated Schools in Columbus, Indiana, just down the road. And we have a about 1,000 employees covered in 2,000 lives. And I am here today, and I have participated in the Employers Forum since 2019 because of those hundreds of teachers and teachers' assistants and cafeteria workers and custodians that are back helping our kids make it for another 5 days, just 5 more days.
Countdown.
And we spend about $19 million a year on those 2,000 covered lives, the 1,000 employees, $19,000 per employee. About, I'm going to say about 4 of that comes from employee premiums, and about 1 million of that comes from the perverse PBM rebate system that I can't seem to push back against enough. So that's employee money as well that's coming back to us, that goes to the plan for everyone's benefit. But like many of you, I found myself like vacillating back and forth between hallelujah during that last panel and then being like physically angry about things during that last panel. It was terrific to hear all of your perspectives. But what I'm going to say about data, I hadn't prepared to at all until seeing that panel. And the data is not enough. The data is not enough. So I am engaged, I think, almost as much as you possibly could be, considering the fact that I have another full-time job that my predecessor said, you're going to spend a lot more time on health than you ever could imagine. And I said, yeah, right. And then I spent twice as much time as that. But we have sent, we joined the forum back in 2019. We have flown employees to the islands to get their Humira. We have signed an agreement to require employees to go to Centers for Excellence for spinal care. I listen to health podcasts while I mow my grass, so thanks for the recommendation on that. When Super Bowl commercials come on for drugs, I pull them up and see how much they cost. I am as engaged of an employer as you can be, and in spite of all of those things that we have done, it has had no effect whatsoever. The only thing that has had an effect is the work that the Employers Forum, working with legislators and speaking as one voice, that has had an effect for us. We don't have the internal expertise as a medium-sized school district, but certainly a small employer. We don't have the expertise to take the data and know what to do with it and use it in an actionable way and a proactive way to stop claims that shouldn't be there, or to prevent drugs from being on our plan that shouldn't be there until it's well after the fact. And we hear other employers say, oh, I heard about this antacid and ibuprofen that's combined and costs a ridiculous amount of money. And then we look at our plan and, well, there it is. I had no idea. It's been there for 5 years now. So, if I taught high school as a middle school assistant principal and an elementary school principal, if data was all I needed, I could tell you at the middle of a kid's first grade year how many are going to graduate, how many are not going to graduate, how many are going to pass our standardized test, and how many are. The data by itself is not enough if you don't have the access to resources or expertise in order to use it in a system where, this will be my last point, my last rant, in a system where there is one fiduciary right here. The system that is set up to extract as much capital, as much money from us as an employer as is possible, there is only one entity that is held responsible for using those funds in a way that protects our employees, and that's this guy. And the last thing that I'll say is that the only thing that we are left with as employers is to shift costs to our employees. That is the only way in that system. If you want to keep costs low, you shift the cost of actual care to your employees. And I know we're not alone as employers looking for employees, but public school teaching is not moving its way up the ladder of aspirations for young people. So in a place where teachers move from district to district all the time, just right down the road for just a couple of $1,000s, we can't do that. So we can't go with the route where we say, hey, we're only doing catastrophic coverage and everything else is on you. Save some money in your HSA. Good luck. because they'll just leave and go right down the road. So employers of our size and in our industry, we need fundamental changes to the system that help us, or we need access to the expertise with that data that we can access to make decisions in a way that help our employees.
Well, with that, Chad, let's start with the first question for you. I want to pull a little bit. You are a small employer, and that can be challenging. So can you talk a little bit about what data you do have access to, what your constraints are around getting that data, and have you been able to accomplish anything with some of the data you do have?
I'll say that we probably can get access to the data that even large employers can. All I would have to do is probably ask for it. One of the benefits of being small is we also have good local partners, that are, I can pick up the phone and call the CEO of our TPA, and he'll talk to me and say, yeah, I'll send you what you want. But again, what am I going to do with that data once I get it when we don't have systems dedicated to that? And really, honestly, shouldn't. Is that how you want your public school district to be spending their dollars, is on, data analytics systems for our health claims? Or do you want us to spend that on great teachers and principals and so forth? So we have access to the data, and we do look at it. The chair of my health trust is back there, John Green. We do get these reports once a month, and we scan through it. But it's not enough for us to be able to say, are spinal procedures hurting us compared to the market or compared to what we would if we went to this other provider? We just don't have that level of ability to use that data, even if we had it, in a way that gets us to make change. Particularly, if the increases from year to year are just a little bit, if we can keep things just manageable, and then so we can dedicate our time and energy towards the things that we're paid to do, like pay attention to your children. We're going to do that. And if it's just a couple 3% each year, and our employees can live with it, that's where we live. And then you have a catastrophic claim or two somewhere, and all of a sudden you have to raise 7, 8, 9%, and that's when you start digging into the data and saying, oh, there's that drug that's been on the plan for the last 5 years. We should have seen that 5 years ago, but we don't have the systems to do so.
Yeah, it sounds like you basically have no staff available and probably no funding to hire staff to do this. So you're probably relying on consultants or other partners. What have you done in working with those individuals to get data and around the work you're doing in this area?
Yeah, we have consultants just like everyone else, and it's funny it's probably like this in other industries too, but everybody says, we're doing a great job because we've got the best consultant. If you just worked with our consultant, they'd be great. I'm like, yeah, then you get one hemophilia patient on your plan, and next thing you know, your consultant's not all that great anymore. So we worked with them, and I feel like they are working hard on our behalf to negotiate with providers, and we have evidence of that. And I'll tell you, they're the one vendor that we work with that tells us, because we required it in our agreement with them, this is exactly how much you pay us. This is exactly how much we get from all the streams of revenue because of your business. And they disclose that to us at least once a year, usually more often if they get a bonus for something.
Yeah, that's great.
It is very nice. We have a great relationship with them. But I have not heard from them that they have access to these resources that can very easily say, take your data, plug it in over here, and it kicks out and says, here are the 3 things you need to do next year, or the 3 things you need to do next week in order to save your employees money.
Yeah. Let's go to Candace next, if we want to, or I can share my mic with you. So on the flip side, you're a large employer. You probably have a lot more resources. How are you using your data to make decisions? You said you are a self-professed data nerd. What are you doing with that data? And what barriers do you see as a large employer?
Sure. So Christan says that I have a lot of resources all the time, but she tells me that all the time.
I'm just jealous. She has more than me.
So first, I was trying to figure out how to kind of frame all these thoughts. But so at Purdue, we think about our healthcare costs in kind of three ways. Obviously, cost. We also want to look at quality of care, and then we're also looking at the overall population health. So we always keep those three things in mind. Our board of trustees not only put that charge to save the money, but they have an expectation on the cost share. To kind of get back to Chad's point, we've not hit that goal. We could do it, of course, in 1 year, but that would be devastating for our employees, me included. I'm one of them, right? And so we've put in a lot of different programs, which I'll get to in a minute. But as far as resources go, I think we've grown in putting together our resources that help. I do have a very strong, knowledgeable, very passionate group of employees on the team, and they really love benefits and data and information just like I do. And I do think that that's very important, because if they're not as passionate as you are, if you're leading the group, then it's going to be really hard, because it's not easy to make change. Employees and family members don't always enjoy being disrupted, but we're not afraid to do that. We spend a lot of time on education and sitting with employees and families individually to hear their experiences as well. But we do have a larger team. I have a group of folks that all they do is benefit data, not just healthcare, right? They have retirement and leaves and things like that, but they spend their time on data. I also have a team of service center, so they get lots of questions about human resources, but a bulk of it is benefits, as you can imagine. And so they spend a lot of time educating and communicating and learning all of those things. And then we have a team of administrators who have responsibility of various benefits. So it's their job to understand plan documents, policies, have that relationship with vendors, manage those contracts, and understand the reports that are coming out of it. Another key resource that we do have a strong partnership with our consultant. I would say they're an extension of our team, and they tell us often that we operate differently. So many of our vendors, our expectation is they come to us. They can copy our consultant, but our consultant is not they don't represent Purdue. They are not Purdue, and they could be gone tomorrow. And so it's Purdue that you're working with, and they're just an extension of the team. They bring different skills to the table, and that's what's important to have, is all those different skills at the table. And then we rely a lot on our vendors, and we've moved that over time as well. Our enrollment platform, we expect them to manage errors that come from data and things like that. And so that's important too, because that takes time off of my team, so that they can concentrate on other things. And we've built into our expectations with contracts. So if you're not going to share the data with us or share or connect with our enrollment platform, you're probably not going to be a partner with Purdue. And so it's just become part of the process. You have to share data with us. You also have to share data with our data warehouse partner. And if you're not going to do that, then you're not going to be a partner with us. And so we didn't used to do that, and it got us caught, and we realized we couldn't get access to data that, even though we're self-funded and we believe it's ours, the vendors said, oh, nope, it's proprietary. And so next way we could get rid of them, we got rid of them, and we went to somebody who would give us data and would allow us to have access. And we rely on that third party to help us report on all programs, clinical, vendor, everything. We'll take, our TPA's reports. It's great. There's nothing wrong per se about them, but we're going to rely on our third party to really tell us. And they put it all together too. So I can run data across different programs and kind of see what's going on as a whole, and not just with this TPA or this vendor in particular. Some of the solutions that we've done, lots of things, but we focus a lot on preventive care. That's been our focus since 2018. So just get your physical, get your biometrics, and then using the data over time, we've now added wellness screenings based on sex and age. And you get incentives for that. You get additional HSA money in your fund to do that. And what we've been able to do, as most of you understand preventive medicine, is catch things early, catch things in earlier stages. It's much cheaper to take care of somebody, but also just helping people establish care with somebody is really important, because then they don't go to the ER when they have a cold, right? Because they have a primary care provider, or they have a clinic they usually go to. And so we've seen that over time be reduced. We have done direct agreements, hips and knees, physical therapy. We have a strong clinic partner, and we run a lot of our programs through them. We expect them to do referrals for us and use the data that we have from claims in order to drive care. We also use their healthcare expertise. So if they're referring over to Chris, for example, but she's not really good at communicating back after the referral has happened, then the clinic providers will say, maybe Chris isn't that great of a partner either, right? And so there's got to be some of that. We watch the claims, but we also understand the way the industry works, and we have to have good partners in that manner as well. Barriers, we use our data, but there's so much data. And so we know that there's so much that we're not using. And so, what's next? And that will be, that's kind of a constant thing for us. And then I mentioned it earlier. We have a lot of vendors or programs in place, and each program or vendor could be doing a great job, but looking at it holistically can become overwhelming or just be a task in and of itself. Because again, we want to look at cost and quality, and also just the overall population health. We're a higher ed institution. Christan knows this too. We typically attract people and we keep them. We keep them forever.
Seriously, forever.
Forever.
If I'm 90 and still working.
I think it's a good thing, and it can be a bad thing. I mean, the good thing is that we focus on preventive care, and so I know the investment now in incentivizing someone for preventive care, we're probably going to see the benefits of that long term, because they're not necessarily leaving us in 2 or 3 years and going to another employer, like to IU or whatever, right? But they're ours forever, right? And so we attract, and higher education is a stable work environment. And so many times people come to higher ed institutions for the benefits and the stability. And so we can attract individuals that are higher risk. But we have to take care of them just like everybody else. So that's why putting in these programs and helping drive folks to the right places is so important. The last barrier that I would say is, and I just lost my thought. It just flew right away. Age, yeah, it's age. Yeah, that's what it is. I'll think of it later, and it's brilliant, I'm sure.
Well, I think when we talked, it was just the timing of getting data. I know there's always a lag, and I know there's been some discussion today even about getting data on a daily basis, and I'm just like, gosh, if we can get it, about a month or so after the
45 days after the quarter ends, right? Something like that.
Yeah, so I think that, at least for us, and I'm sure for you, is a barrier for employers.
Yeah, it is, because you're always making decisions in kind of, you feel like in the past, right?
Yeah.
I think it's not really a good thing about that, but we're just so large, and we've been large like this for a long time. And so we are our own trend. So we can kind of see things over time, what's happening, and can be pretty consistent. But yeah, the lag on data is very difficult to address, because it comes, there's a lag from the TPA that goes to the data warehouse. Well, then they have to have time to put it all together and pump it out into our reports. And then there's that lag. And then we all have to get together and even look at the data and then contemplate, and what is it doing? What did we expect it to do? What did it do last quarter? So the whole thing just takes time, and can feel very monotonous and make you want to hit your head on the wall. But
yeah. let's transition to Cora, because we've heard from a small employer perspective, a large employer. You're like super large, but with the union twist to that, which I find very interesting. You're based in New York. You mentioned basically, essentially, unions offering free health care. That can be difficult to manage, everything's free. What have you done with your data? You mentioned a little bit earlier in your intro, but what are you doing to use your data to best position your employees and your, overall healthcare spend?
So I think the reality of this is that we actually have to kind of jump in the Wayback Machine and go back and recognize that this has been over a 10-year process to get us to where we are. And I think that's really important. And, and I know that Melina, you sort of mentioned this too. And I think that so have you, Candace, is that I think it's really easy for us to think that, if I just get this, I'm going to pretend like I'm a data nerd. I am not. If I get my, comma delimited file or with my claims data, I'm just going to magically be able to solve things. But the reality is it doesn't actually work that way because, and I think Chad, it's a shame he had to leave because I think he had it best. What am I going to do with the data once I get it? And this really for us started over 10 years ago. Back in 2012, there was an RFP. And at the time we were with Anthem, we switched to Cigna. It was just an unmitigated disaster for a lot of reasons. And union folks have very long memories. And I'm sure, Candace, you can speak to that. Because I will say, fast forwarding all the way to the last year, we've gone through an RFP and every single conversation for the first 9 months where you can't let what happened with Cigna happen to you. Got it. We're just in a very different world now, but absolutely we cannot let, and part of the reason it happened is because we didn't have our data. Members were going out of network. Claims were being paid at 90% of charges, and there was a 10% shared savings fee, and all of a sudden the bills became more than the contributions coming in. And it was at that time that the employers and the union came together and they said, hold up, this is not sustainable or tenable any longer. And so that was really when the task came out to the health fund to figure it out. And really it was where we've started to take this more proactive approach to managing the benefit. Instead of relying on our carriers and our ASO to tell us what the answers are, it was, okay, how do we bring this in-house? We hired a data analyst. And I will say, because I would have challenged Chad, I actually believe that everybody should be able to hire a data analyst. If you hire a data analyst, they should be able to find their salary's worth of savings for you. And if they're not, you have the wrong data analyst, you don't have a better plan. Period. So I would challenge anyone that you should hire a data analyst. So we hired one. Now, by the way, I have 8, plus like another 8 people who are data engineers who ingest all of our claims data. We get it for all of our vendors. But it was a process. And it was a process because we recognized we couldn't rely on other people to do what's best for us. Fast forward to 2018. So over that time period, we started looking at the data and we were going, this is interesting. Why am I paying so much difference depending on where I'm going to get care? New York City, very fortunate. We have 5 academic medical centers, a city hospital system, and a safety net hospital system. So in a lot of ways, we have 7 different avenues for members to get health care. But we also started to look at that and said, why in some hospitals am I paying 400% of Medicare? Thank you, Rand and Chris Whaley. And why are we paying 100% of Medicare at the city hospital systems? And so the health fund and the board of trustees at the time said, you know what we're going to do? We're going to tier our network and we're going to do it based on price. Because also, as Chris, beautifully articulated in his graphs, quality and cost are not equated. And so we knew that by tiering this strictly based on price, we could still offer a really great benefit to our member. That was also the first time we really ran into the anti-competitive contracting terms that exist between carriers and the hospital systems. And so many of them. At the time, we said, okay, so for those of you who are familiar with New York City, NYU, Langone, New York Presbyterian, Northwell, and Westchester Medical Center, all of you all are going to be non-preferred. And for inpatient hospital, you're going to have a $1,000 copay. Everybody else is preferred, and you get a $100 copay for inpatient. And New York Presbyterian came back and said, great, but according to our contract with Anthem, we must be preferred if we are in, because our requirements are, we have an all products clause, we must be preferred. And we said, I'm sorry, many union folks go, I'm sorry, what, you get to decide our benefit? Turns out, yeah, a little bit. Which, again, we'll go back to the anti-competitive contracting terms between hospital systems and carriers are something that we need to continue to look at, and I know the previous panel touched on that. So that was 2018. We did end up being able to tier the network. At that time, New York Presbyterian was non-preferred in Manhattan only. So in New York City, there are 5 boroughs. In one of the 5 boroughs, they were non-preferred. All of their outer borough hospitals were considered preferred. So that was the way we were able to thread that needle of the contract requirements. So now going on, by the way, throughout this whole time period, the union started talking to their members. And I think this is so important because you really can't make change without talking to the people the change is going to impact. And I refuse to use the word disruption now. And because it's only disruption if something is working. Our healthcare system is not working. Therefore, we're making change. So the union started talking to their members and they started saying, you know what, this is not working. We need to make change. We need to ensure that the benefit's going to continue. So fast forward to 2021, and the contract between New York Presbyterian and Anthem was up for renewal. And New York Presbyterian said, we now must be preferred. And if you have any programs in your benefit that do steerage, we have to be steered to. We have to be included. So for us at 32BJ Health Fund, right around in 2020, we launched a high-value maternity network where moms in our plan could have a baby for no more than one $40 prenatal copay. So for any of you who've had babies, it was just Mother's Day yesterday, I'm guessing your bill was more than $0. And we were in a position where we were being told that we would have to, and the union said, I'm sorry, again, hold up. Why does a hospital get to dictate the benefits we have? So it became a very public fight. I'm not sure I'm not supposed to use that word. Very public debate. And it was determined at that point that 32BJ Health Fund could go out of network with New York Presbyterian with Anthem. And so on January 1st, 2022, we removed all of New York Presbyterian hospitals and affiliated physicians from our network, impacting about 25,000 lives in New York City. And I want to really point out the fact that it impacted 25,000 people because it's never easy to make decisions like this. But we did this and we did it with the membership. I think the health fund themselves, I think we called and talked to members, I jokingly say 17 times, but it probably was close to that. The union talked to their members. And because of the cost savings, we estimated that we would save about $30 million a year. And that estimation has been proven because we have really phenomenal data analysts, been 100% spot on. So for the last 2 years, we're now looking at a cumulative of about over $60 million just because, let me be clear, members still sought care. They just sought it at a lower priced provider. So we saved $30 million that first year. That savings was then able to be returned back to the members and the employers. And we did that in 2 ways. And I know it's been touched on a couple of times earlier this morning, but I think this is really important because you can't make change without creating win-win solutions for the employers in the audience, via the internet, live stream. Is that we have to remember that it impacts us and it impacts the people receiving the health care. And this win-win solution we were able to create by making this very, very hard decision that impacted real people. But it was able to go back to the members in the largest wage increase in the union contract's history and a $3,000 bonus to the members. And then on top of that, to the employers who are paying for 100% of these premiums, we gave them a 2-month premium holiday, which essentially netted out the premium increases to 0 for 1 year, and that our premiums will not go up more than 3% over the course of 24, 25, 26, and 27. And so I kind of just want to highlight that real quickly, and it's because we made hard decisions, but we did it in conjunction with our members. And again, I'm going to go back to challenging every single employer out there is that you can do this too. It's really easy to say, well, you did it because you're big or anything, but there are plenty of folks up here earlier that were talking about being these small employers, and Melina will talk about the way the changes and the savings that we're able to do it. You just have to have the guts to just stand up and try it. I was trying to come up with a better word, but I don't have it today. It's, 4:00 for almost 4:30, But I do want to say we did that in 22, but we were not about to rest on our laurels. And so we recently went out to RFP for our medical carrier, and we did something a little bit different this time. What we did is we went out to RFP and we said, okay, here's this really, really long questionnaire that we worked with a consultant on and probably rewrote most of the questions. But we also sent a 70-page contract out to the carriers and said, you must redline this before we grant you the business. And so when we hit down to our finalists, we had 2 carriers and we had 2 redlined contracts that protected our interests. And this draft contract will be available starting in the next couple of weeks to anyone who wants to see it. Mark Cuban said, share your contracts. Well, I can't share the final one. I can share you the draft one. And it talks about the increased audit protections, the ability to remove and have visibility into the anti-competitive contracting terms that are out there. Things like upside down billing, which is just like breaks my brain every time. The fact that you can actually pay more than the doctor charges. We have things like the ability to have, visibility into things we didn't have before. And I only share this all as to say that it's not easy. It is hard, but it is doable. We just all have to be able to be willing to do things a little bit different.
Awesome. Thank you. Well, I know we're running short on time, and I want to get to our last 2 panelists. So, Melina, you have yet another perspective in that you represent a lot of self-funded health plans. You mentioned earlier you're helping employers customize benefits. How are you using data to kind of inform what you're doing to support your employers?
So I'm totally the wrong person to give them 5 minutes to talk, but
Oh no, you have a little extra time.
maybe
don't.
7, I don't know, or 3, I don't know. So I'll try this. So I joined the Alliance in 2017. And as I said before, by the way, I'm a data geek. I have a PhD in analytics, so I'm completely a data geek and a benefits geek. I love benefits. However, I do sales and marketing. So my first prospective call with a prospective employer at the Alliance, he wagged his, he was not a member yet, wagged his finger to me, and he said, do not underestimate free healthcare. What an intriguing thought. And it just spiraled me down to a path of looking at data and looking at providers. So, despite my accent, I don't come from the land down under. I come from Wisconsin. And Wisconsin is, well, I don't really originally come from Wisconsin, but I live in Wisconsin. Wisconsin is the land of the HMOs. HMOs means narrow networks, capitated contracts, opaque, no transparency. None of the hospitals that own their own HMOs Every single hospital system, I believe, in Wisconsin owns an HMO, with the exception of Mayo. And Mayo is not domiciled from Wisconsin. They have a couple hospitals in Wisconsin, but they're not from Wisconsin. So I don't believe that any of the hospitals share in hospital price transparency their data for the HMO, their own owned systems, the HMOs. And no data. So when employers come to self-funding and they leave the HMOs, they have no data. So I started looking at oh, by the way, physicians, 90% of physicians, providers, are employed by the systems. That discussion that we had before that, I finished my medical degree, I have my own office, then I get a really sweet deal from the hospital. That's what has happened in Wisconsin. So we started looking at the data in 2017, trying to crack that thought of free healthcare. And we needed to identify independent physicians, not a lot of them, independent providers, not a lot of them. A couple of our systems came to us, or we went to them, and we got preferential contracts if we would help steer to them our employer, our patients. And so we did that. We started what we call, if you go to our website, we started what we call the Premier Networks. We have done that successfully. And as we started steering patients according to cost, some of the ASCs, the ambulatory surgery centers, the independent providers started developing, their offices, their practices. And here, so I'm not going to go through 7 years of history, but here we are today. And through data, because we are the watchdog, not only we own the contracts, but we are the watchdog of our employers' data and our employers' healthcare costs. We do customized reports for employers, and we share with them a lot of information. What is their risk? What has been their risk over the past 3 years? What is the risk today? What is their risk going to be next year? And with that, what do they expect high-cost claimants? What are their high-cost claimants? And what do they expect their cost of these high-cost claimants to be the following, so predictive modeling, the following year. Very importantly, where to steer to, how to tier the network, how to identify the right benefit design for them, and how to steer to high-value providers. We call them preferred value because we don't have all the quality data that we wish we had. We're working on that. So high value means quality and cost. So we call them preferred value. Today, 81% of our employers are using our data to steer, and most of them are offering zero copay plans. So they're offering the top benefit tier, including, by the way, the Alliance as a self-funded employer, a top tier of place of service associated with cost and quality at no additional patient responsibility. This year, my husband, PHI data, right? But I'll share because he lets me share it. My husband, actually 2 months ago, just had brain surgery. So this year, we're going to spend a little bit of money on our healthcare. Last year, neither Peter nor I, we spent zero out of pocket in our healthcare. And we have employers that have maintained for multiple years their benefit design. It's improving the out-of-pocket for their employees and their families, and it's very successful. Now, I'm going to turn it over to Candace because we're running out of time. But Chad, before he left, mentioned hemophilia, right? Are you familiar with hemogenics? Hemogenics was approved by FDA in late, I believe, November of 2022. It will cost when it comes out in the market. It's getting ready to come out in the market if it's not already. It will cost $3.5 million. It will be the most expensive drug in the world. They don't say that it cures, but what I'm hearing from my pharmacy friends is that it cures hemophilia. It is a life-saving drug, right? How do we watch are spent in the RX space, however. Mark Cuban was talking about GLPs. GLPs are nothing compared to gene therapy and biologics, right? And that's what's coming out in the pipeline. Not the GLPs, not obesity or diabetes medications, but the gene therapies and the biologics. Now, full disclosure, I'm a vice chair of the board of the organization, I will mention. But there is, like the Alliance, there is a national RX watchdog. They're called National Cooperative RX. They're a coalition of employers for 150,000 lives. And that's what we need. We need, so business idea out there, we need watchdog groups. We need the groups that, for employers like Chad that cannot, don't have the staff, we ingest the data, we look at the data, we give actionable insights, and that's how it's done. And it's not easy. It has taken us a very long time. We've made an incredible investment in this, continue to make an investment. It takes money and time.
That's interesting. If we had more time, I would have about 15 questions for you on that. So maybe we do that in a future forum meeting. Chris, last but not least, we've heard from different employers and from your consultant expert perspective, your area is fiduciary responsibility. You've heard from everyone today. Can you highlight why data is such an important piece of managing a healthcare plan, and what recommendations do you have for employers to be able to act as a good fiduciary?
Great. I think I can get that in my allotted time. But I would be remiss, and I'm very upset that Chad has had to leave, because I wanted, and I think we have to lean into uncomfortable conversations if we're going to change healthcare. So it's going to probably be a little uncomfortable here, because I was going to challenge the statements that he made. I do not want Chad teaching my kid. Chad said he was the CFO of his organization, right?
Yes.
He didn't say he was a teacher. He didn't say he was in charge of curriculum. He was a CFO. And if I'm a taxpayer in Bartholomew Consolidated School District, I want Chad paying attention to the $15 million or $20 million they're spending on healthcare. And that is why, and that's what Chris Gizak talked about before, that is what is wrong, is the mentality that the CFOs, I guarantee you, if I asked Chad, and I was going to ask, what do you spend on transportation? How much do you spend on buses? How much do you spend on drivers? How much do you spend on gas? You'd be able to tell me each of those line items. Should be no different in healthcare. And again, it got me a little hot to hear that there was sort of this willingness to say that this isn't what we're paid to do. This isn't what we should be looking at. But it is absolutely what you're paid to do. It is absolutely what you should be looking at. And that is the mentality and the focus you need to bring. I guarantee you look at duplicate claims, one piece, right, and have a data analyst looking for duplicate claims and upcoding. You're gonna have a 100 to 1 ROI on one data analyst. So with that in mind, and it is important because it does have to do with fiduciary obligations, and the fiduciary obligations that folks like Chad and folks like myself who served in the state have to their taxpayers and to the teachers who are foregoing wages in order to pay for these health benefits. So what does it mean to be a fiduciary? Very short and simple. When you are entrusted with other people's money, right? You now have a fiduciary obligation to take great care with it. Every 2 weeks when my employees are getting their paycheck and there's a line item taken out of that paycheck to pay for health benefits, I'm entrusting you as an employer to purchase my healthcare and my health benefits coverage prudently on my behalf. You've now triggered your fiduciary obligation, and it's specific under ERISA, but if you're a public sector employer, it is not a lessened or a responsibility that's gone away. Arguably, it is heightened because you are dealing with public dollars and the public fisc. More specifically, what does it mean to be a fiduciary? It means you have to act in the sole and exclusive interest of the plan and plan participants. It's called the exclusive benefit rule. You have to act with prudence, That is a heightened standard of responsibility. It's not just, what is my friend doing? What is my neighbor doing? What is my sister school district doing? I have to act with a heightened standard of care, and that is the standard of prudence. I have to follow my plan documents. I have to hold assets in trust. That means when you deposit or give me a part of your paycheck, or a part of the taxpayer fisc, I have to hold that in trust. And I have to only, again, spend that money prudently. And then I have to pay only reasonable plan expenses. And that sounds very easy, but in healthcare, it's far from it. And we make it very difficult, and when I say we, I mean the industry, makes it very difficult to know not only what is reasonable, but actually what you are paying, right? I can look at a hospital price file and I can see that charging 500% of CMS is not reasonable, right? But what is reasonable? Okay, maybe 125% of CMS, and I can see that on a file. But unless I know what's coming out of my bank account and going to that hospital, it is very difficult to judge what is reasonable. And that's why you have to have your data, right? So you have to have your data. And not only do you have to look at data that's in, TIC files and the hospital price transparency files, but unless you are looking at what is coming out of your account, you do not know what you are spending your money on. And I mean at a very specific line level. And not all data is created equally. Like getting reports every quarter, that's a start. But unless you are getting claim line level data, you do not know what you're paying for. And I'm going to bring up a couple of cases that are going to really illustrate why this is so important. So recently, the Department of Labor filed a lawsuit against Blue Cross Blue Shield of Minnesota. And in that lawsuit, Department of Labor brings this case on behalf of self-funded employers in the state. The allegations are that Blue Cross Blue Shield of Minnesota, undisclosed to the employers in the state, added taxes to the claims and then passed those along to the employers without their knowing it. So the provider submits a claim to Blue Cross Blue Shield for $100, as an example. Blue Cross Blue Shield of Minnesota adds a provider tax, which is going to fund Medicaid, different story for another day, but adds a tax and then passes that $120 claim onto the employer without telling them that $20 of that is a tax that they've added on. Right? Okay, so $68 million lawsuit against Blue Cross Blue Shield of Minnesota on behalf of self-funded employers in the state. Now, the most interesting part, and probably what should be the most disturbing part for every employer in the room or anybody that cares about employers in the room, is that Blue Cross Blue Shield of Minnesota's response back to the Department of Labor was our provider contracts with the providers who we're collecting this tax for allows us to add this tax. It's part of our negotiated contract rate. And because the employers in the state of Minnesota have signed ASO contracts with us that say we agree to pay the negotiated contract rate, they're bound by that term. They're bound if we agreed to add on provider taxes, if we agree to pay provider, value-based payment, performance payments. Really, the position that they are taking is if my contract, if I'm Blue Cross Blue Shield of Minnesota, if my contract with my provider hospitals says that I can add on fees, taxes, performance payments, you name it, you got it. If I want to add that on and pass that along as a claim, if you, employer, have agreed to pay my negotiated rate, too bad for you. You've agreed to whatever I agreed to in that provider contract. And oh, by the way, you don't get to see what that provider contract says. Now, this case is still working its way through the courts, and I'll be following it and updating folks. But these are the types of things that, unless you are looking in your claims and you are doing a good job making sure that your contracts are solving for these types of things, you could be paying, and I was having a conversation with somebody at lunch and sort of describing how this plays out in practice. You might think that you're paying a provider $100,000 for a claim, when in fact that provider only got 80 grand of that, and it was $20,000 was kept by the middleman for any number of add-on, tacked-on fees. This is happening, and it's happening to you. And it doesn't matter how great a partner you think your TPA is or how great a partner you think your consultant is that's overseeing these things for you. It is happening because I don't know any employers today that are looking at claims at that level and then actually able to do something about it. I have several action items that we don't really have time for that I would love to share with you. I'll make them available to Gloria, and really it's language, it's verbiage that you can take and send to your consultant or send to your TPA to say, I need to know if this is happening to me. Another example of some of the litigation that's ongoing that you should really be paying attention to and asking questions about is recovery services and out-of-network negotiation fees. You might have seen recently on the New York Times main story. It's been happening for well over a decade, but it was news to the New York Times, so it should be news to everybody. But you are likely paying recovery services fees that your contract likely allows for you to pay or for them to charge for out-of-network negotiations that are taking place on your behalf. What you might not know is in many cases, you are paying more to your TPA and to those out-of-network recovery vendors than you actually are to the provider. But unless you're having them break out those fees, you don't know that. Right? One of the cases that was highlighted in a recently unsealed lawsuit in California showed that on a claim, it was an $11 million claim that was negotiated down to less than $1 million by Cigna and their out-of-network recovery services vendor. It was a behavioral health claim. The provider got less than $1 million. Any guesses on what Cigna kept? 30%? Yeah. $3.5 million. The recovery services vendor got about $675,000. But the employer that got that claim thought that they paid $1 million plus the 3.5 plus the 675. They didn't know that they only paid the provider $1 million because they weren't looking. And now this is going to be the subject, I believe, of the next wave of lawsuits by employees against their employers, because if that employee was on the hook for any of that out of pocket as a co-insurance, because a lot of these are out-of-network providers, that's one of the real weaknesses in some of the cases that have been brought in the Johnson & Johnson case, in the employee versus employer fiduciary breach cases, is the inability to show real harm, financial harm to members. 20%, right? Going to my TPA as a kickback, that's financial harm. And that is going to be, I think, part of the next wave of litigation. So put a little fear of God into you there. But anyway, I'm going to give Gloria some resources, and you will be able to take some of this language and you can copy and paste it into an email, make it your own. But you will get to, am I paying these? What is the rate that I'm paying this at? How can I look at these fees and have them broken out so that I'm not sort of falling victim to what some of these egregious practices are that we're hearing about more and more in the news cycle? Thanks.
Thank you. Thank you to all of our panelists. I don't know if we have time for questions. Probably not. 5 minutes. If any questions, we have a couple of minutes.
So while we're waiting for questions, 30% for out-of-network, for TPAs to bring in an out-of-network repricing network, right, to an employer, 30% has been the standard for decades.
30 to 50.
Yeah, decades. And I don't think that employers know that. Yeah.
No, and I certainly don't think they have any idea that oftentimes they're paying more to the out-of-network repricer and their TPA via kickbacks than they are to the actual out-of-network provider.
Right.
Yeah, for sure.
But it's standard in the industry.
Yeah,
so
absolutely.
Kudos to New York Times that didn't know that.
Yeah.
We'll start with a question in the room over here.
Thank you very much. It was an amazing panel. I'm Sean Grimminger with the National Alliance. So, Cora, you gave me sort of a layup question, so I'm going to give you one because this is something we've talked about. How do you've been both really aggressive on the purchasing side of things, which is incredibly impressive, but you also are very active and working hard on the policy side of things, both at the state level and federal level. As an employer, how do you map together kind of your purchasing clout and the work that you're doing with the policy clout in a way that's cohesive?
Excellent question. And I think the short answer is because we've learned that being a purchaser is not enough. And that the reality is you have to start to, is that I think employers really have to start to tying in the policy work. We have Emma Clippinger from the Office of Healthcare Accountability in the city of New York. And that came in part because of the work of the 32BJ union, not the health fund, the union. Important legal distinction that I don't totally always understand because not a lawyer. But we also recognize the reality is we did attempt to pass the NASHB model legislation on anti-competitive contracting terms, and we passed a very watered down version of it because that was all we could get done because of the hospital lobby. But that shows you that, we've learned that we can do so much as purchasers, but until policy either catches up or helps pair that together, we've learned that's really one of the ways that we can do that.
Excellent. Online question over here, Sarah?
Yeah. Okay, so I have two from the same person. One's a question, one's just a comment. So the first one being, the Department of Justice just announced a new task force to focus on antitrust in healthcare. Do you see any avenue for us to get some issues addressed through this vehicle? So,
Chris, that seems like it. Your ball of wax there.
Well, I am not bullish on solutions from DC. I think this puts it best, right? 3 weeks ago, United Healthcare CEO made it up to the Hill. It was grilled for 3 hours. He took it from every congressperson up there. United Healthcare stock just went up. Right? We can do a lot of theater and we can announce, Office of Healthcare, what competition was a new one that we just got. We can, announce task force, and the truth is, if they are going to make some sort of change or difference, there is definitely going to be a time lag. I am not bullish. I hope that at least it will get some press and people will continue to pay attention. But quite honestly, I'm more optimistic about gatherings like this and political leaders that we have here today that are actually doing the work than flashy press releases at making change.
Excellent. All right. We're going to do 2 questions from the last 2 in the room, if that's okay.
I just have, my last one isn't a question, it's just a comment that he wanted to share with the room.
Sure.
So it'd be quick. So to help us with the amount of data, and sorry, these are both from Patrick Pine online. He said, to help us both with the amount of data, I have engaged my undergraduate and MBA alma mater to have MBA students and data students work on projects to help us assess, find, and gather data as part of their class involved in data analytics. So he's also exploring paid internships.
Thank you. All right. We'll go over here next.
Appreciate that. Dylan Melling with Integrity Benefit Partners. All of you have had in some level work with excluding or tearing down what are probably popular healthcare systems in your areas. And we've got several CFOs, CHROs who are saying, hey, I see the data. I see what this is, but I'm frankly terrified of my people if I do this. Any tips about the rollout and how you create that buy-in from your employees to get them to see this as in some cases improving some of your stories, in some cases financial shifting here? Any tips on how you create that buy-in with those employees?
Talk to them. I mean, it sounds ridiculous, but I'm serious, because the other thing is unions are uniquely, and union members are uniquely suited to understanding that $1 in health benefits is $1 not going to wages. We've done a ton of analysis, and we know over the last 10 years, had healthcare inflation gone up the same as wage inflation, our members would have had $5,000 more in their pockets than they do now annually. So if you were to turn around to your employees and say, you know what, your premiums are going down, you're going to have better wages, that you actually return that savings into it. I think employees are rational people. I think we sometimes forget that we get caught up in healthcare is hard and they're not going to understand. But they understand food on their table. They understand rent having to be paid. They understand bills going up. Gas is expensive, and having to make choices about healthcare. And if you can say, look, if we take out this hospital system or we do this centers of excellence, that the savings goes back to your pocketbook, people understand that.
Yeah, and I just wanted to add that employers don't, at least my employers, don't exclude providers. They're still in the benefit plan design. In fact, a hugely broad network. However, what they say to their employees, you can go wherever you want to go. Cynthia said it, or was it Cynthia? Who was it? Somebody before. It wasn't Cynthia. My plan called me and they said, we're not going to tell you where to go, but if you would go there, right, it means you're going to pay nothing out of pocket. So that's kind of, and I will tell you, we have employers where the employees, they introduce these benefit designs, the employees don't believe them. They call me personally, or they call my team. Is that for real? So if I get my MRI, we have employers that not only make these available for free, they actually give them additional incentives, 20% of the same. So it's not about excluding, it's not about a stick, it's about a carrot, right? So.
And we do all of that. We don't exclude anything. We've done some exclusions, but network-wise, we haven't. We spend a lot of time educating. I meet with stakeholder groups once a month and have done that since 2019. And still even educating and being transparent and showing them everything still sometimes just doesn't cut it, I guess, from the employee perspective. And I think that's where I lean on my team, and they're very knowledgeable, passionate. We believe in what we're doing. We're also the employees that are impacted as well. And so I think that's a lot of it too, is that you have to be within your team as you're making a decision. We do have support of the C-suite. That makes a big difference as well, because they're the ones that will get the emails from the employees after they've come to us and, we explain it or we say no or whatever, right? They just skip right over us. So some of it just, you have to believe in what you're doing too, because you're just not going to make everybody happy all the time.
Thank you for your patience. Final question over here.
Thank you. Matt Robbins, Seraph Health. Very curious, Mark Cuban mentioned something about removing the sort of deferred payment schedule and giving providers cash up front as an incentive to enhance negotiation, to get people to work with you, to maybe bring it down to 200% instead of 300. Is that an effective vehicle as you all see it, negotiating on behalf of employers, or is that something that Mark Cuban can do, but maybe the small and medium-sized employers in the room would not be able to achieve?
Yeah, actually, I think it's a very effective. It is so effective that we actually, because we do direct contracts on behalf of employers, we actually have put it in our contracts that the cash price that providers give, it's actually higher than our contracted price. So our contracts are always lower or at the same level as their cash prices. I believe that it's very effective. If you don't have an alliance or an EFI or a watchdog to help you out.
Yeah, and if you were to talk to any hospital and pay attention to their CFO reports or their revenue cycle management, their pain point is, what is my 30, 60, 90, 120, right? What are their receivables? They know every 30 days they're going to have to go out and chase more. They're getting pennies less on the dollar. Cash is king. Cash is king. And they absolutely, and what is it? I think it's 4-to-1 admin, 4 admins to every provider from a patient, how many people they have to have chasing people for money. If you solve that problem for hospitals, they will give you a great price. So it's absolutely something that Mark's spot on with, and I think is going to be part of the future.
So how do you align that with the fact that most of the hospitals, at least in Indiana where I'm from, are not-for-profit hospitals?
Well, I think cash is king for them today as not-for-profits, and cash will be king for them, tomorrow if they're paid cash up front.
Right, but they're sitting, I mean, I think it was Chris's slides showed how much they actually really had, but yet they're chasing these dollars, turning people over to collections for a $100 bill, but they're a not-for-profit entity and charity care is, this much.
Right. I mean, what better way to take away that service line of we have to chase people for money and we don't get paid because of, right, cash tomorrow versus chasing somebody for 120 days? It's just the reality.
All right, I think that's it. Thank you all.